This week's podcast topic comes from Sam, who wanted to share his experiences of being in his 20s. And really, what he wanted to get across is, what do you expect when treatment options end? And I have the lovely Jonathan Koffman here with us as well to share his expertise as a professor in palliative care. So welcome both of you to the podcast. Sam, we've just had you here doing the episode about stomas and meetups. But Sam, in case somebody hasn't seen that episode or heard it, can you tell us a little bit about what was going on in your life when you were diagnosed?
So I'm Sam. Initially I was living my life as a usual kind of 20-year-old. Just finished university. I went away, lived in Australia for 2.5 years over COVID. So yeah, had a blast over there, kind of avoiding responsibility. And then after COVID had kind of blown over, 2.5 years later, I decided to get myself a place on a master's. So I then moved back to the UK, and at that point I was feeling a little bit unwell. I'd lost a lot of weight. I was having difficulties going to the toilet, and noticed that something was kind of wrong. I'd kind of put this down to like IBS or something like that. I went to the doctors as soon as I landed after coming back from Australia. I discovered that I had stage 4 metastatic colorectal cancer. So the last 3 years I've been undergoing treatment. So obviously they start off with the best treatments they have. They continue to go through the different treatments, but unfortunately my cancer has developed resistance to all of the treatments that they have available. So that's essentially who I am and where I'm at.
Yeah. I mean, such a lot happened in such a short period of time. And when you were first diagnosed, what did you understand about your diagnosis?
So right at the beginning, to be honest, I really wanted to know as little as possible. I trusted the doctors knew what they were doing, and I really didn't want to know the details. Eventually, after 3 years of treatment, those details do get kind of drip fed to you, and eventually you can kind of take it. But initially, I was, I didn't want the nitty gritty, but I did obviously know the severity of the diagnosis, and I knew it was unlikely that to be honest, it was a kind of almost a double think, like simultaneously believing two different things. Although I knew that I had a very kind of slim chance of survival, you kind of never think that it's going to be you. You never think that you're the one that is going to be hit by this, that you will be the one to survive. So you also have that going on in your head as well. On a technical side, I did understand the severity of the diagnosis.
I really liked how you described there that holding two quite contradictory things together and holding that. I mean, for that period of time, that it sounded like you were still sort of hoping. What kind of news in that 3 years were you getting from the doctors?
I mean, the doctors never want to tell a 24. I was 25 when I was diagnosed, and then going on to 28. Anyone that age, I don't think the doctors ever really want to tell them anything too nasty. So the doctors kind of remain semi-positive throughout. You kind of pick up an undertone of but generally they were like, we're going to do this, we're going to do that, but there was an undertone that this wasn't going the right way. Either you have the doctors that are really, really positive, saying, we're going to come in, we're going to do this, we're going to get it sorted. Whereas, I think I tend to, have the doctors were like, we've got another treatment, we're gonna try that. But there was the kind of like undertone that things were kind of slipping away, really.
Did you have any sort of idea or plan for when those treatment options came to an end?
I don't think anyone can plan for that. I certainly didn't. Once again, I was still planning for the nice, hopeful option that we get to the end of this and everything is all happy days and glorious. For the 3 years, settled into a mindset that I would just get my head down, get through treatment, and then kind of get back to my normal life. But it was only really, I think, towards the, kind of maybe November this year that I started to realize that, my normal life is not coming back. And that's when I started trying to make ways to live with the cancer. But obviously, quite soon afterwards, I've realized that, I'm not really going to be able to live with the cancer either.
And so, where are you with things at the moment?
So at the moment, I'm undergoing palliative care. So that means that they can no longer treat the cancer itself. They're essentially giving me medications that are treating the symptoms, so morphine stuff for the pain, and basically just trying to keep me feeling as comfortable as possible for the time that I have left. So that's essentially what it is, and where I am at with my treatment.
And where are you at the moment? Are you at home? Are you in hospice?
So at the moment, I'm in Princess Alice Hospice, which has been absolutely fantastic. Like, it's been an amazing place to come stay. I mean, the plan is that this is a temporary stay. So initially, I was finding it incredibly difficult to manage my pain at home. And the usual option for when things would get out of hand, I would be heading to A&E, which really wasn't an appropriate place for me to go. So they've kind of brought me in here to try and get the drugs, the program, and everything in place so that I can go back home and live comfortably and not have to be calling up and ending up in A&E in agonizing pain, where they don't really do much either. So yeah, essentially they're taking me in here just to sort things out, and then I'll be going home again afterwards.
Thank you, Sam. I'd love to bring Jonathan into the conversation here. Jonathan, how has it been for you hearing from Sam?
Sam, thank you for firstly being so frank about what's been going on in your life. It's humbling to hear accounts like this, whether I've heard them once or many times. These are lived experiences, but it's also the reality not only for you, but for so many people. And I also really mindful to think of the families and close friends who surround folk like you, who are travelling along a different journey and experience a whole plethora of symptoms or feelings as well, which are legitimate in their own right. But bringing it back to you, firstly, I'm delighted that you're receiving really good care at Princess Alice. There are many other hospices which are very similar and offer identical models of care up and down the country. But I think it's also important to bear in mind that palliative care can be offered in a whole variety of different settings. Hospice is just one, so it's important to bear in mind that it can be offered at home. It can also be offered in hospital settings or in nursing or residential care homes. For some individuals who are, just putting it out there, can be offered to people who are the street homeless. So it's agnostic in relation to where it attempts to deliver its goods.
Yeah, and Sam, you smiled when you were talking about the hospice. And I think there's often this, I mean, just even hearing the word, and for many people, and I imagine many of your friends have maybe never been in a hospice before or really known what it is. Like, what was your perception of hospice before? And what is it about your experience now that's brought a smile to your face as you were talking about them?
To be honest, I mean, the aspect of the hospice is kind of secondary to kind of my opinions on palliative care, like in general, really. I mean, at the point that I was going into the hospice, I was, quite excited to go there because I knew that obviously, they would be able to look after me and look after my pain and such. But I think really this is more like my opinions on palliative care in general, because I think I had this opinion initially that going on to, or when the treatment finishes or going on to palliative care, I almost had this opinion that that's when, all treatment stops, and that's when, you're left out to dry and just wait until you die, basically, which is really not a very nice thought. But I think what I've realised, and this includes the amount of time that I spent in palliative care at home, and also the time I will undergo palliative care at home after I leave the hospice, which is planned in the next few weeks, is actually everyone is trying their utmost best to keep you feeling as good as possible. Like, they continue working and they continue doing everything they can. And in some ways, it's actually nicer than when you were, I mean, obviously the outlook, you don't have the same hope you did when you were going through chemotherapy. But at least here, the treatment actually makes you feel better. Unlike when you were going through treatment where the treatment makes you feel absolutely terrible. So in fact, there is a certain time where you make peace with what's going to happen. And suddenly there's no more scary scans. You know what's going to happen. It's already the worst it can be, and everyone's working really hard to keep you feeling as well as possible. And in some ways, that was actually a relief that I was going into this than continuing with this treatment that was just making me more and more sick. And I think that's something that I never ever thought when I was a young, fighting fit adult. I never thought that I would have that opinion, that I would suddenly think that palliative care would be a relief or would even be an option for me. I would keep going till I was literally on the floor. But, it's actually, it really changes your mindset after 3 years of aggressive treatment.
I think it's quite important to put in place that palliative care can run alongside curative treatment for a great many individuals, at the very least to manage some of the very distressing symptoms that might be associated with the illness, but also to manage some of the very potentially distressing symptoms that might be associated with the treatment, and also to pick up on all the other issues, the psychosocial, the psychological, the spiritual and existential concerns that people may live alongside whilst they're having active treatment. Not only for those who, let's cut to the chase, for those who are busy dying, which is where most people understand or believe palliative care exists right at the very end of life. In an ideal theoretical world, it should run alongside from the point of diagnosis all the way through to death. And obviously after that, looking after family members in relation to their grief and bereavement experiences, because getting it wrong earlier along has significant consequences for them. So it may intercede at lots of different points during the journey of receiving quite aggressive treatment, which is associated with a whole bin load of quite distressing symptoms.
It's so different to what many of us understand about that word. And I know this is your area. And so where do you think this misconception comes from when what you've described is very different than what I think we hear about, what we understand?
Hospices were historically places for people who were living with and dying from advanced cancer. That was where the model started, way back in the 1960s. But it has been extended, and for very important reasons, because I often refer to palliative care as being about health gain, in terms of adding life 2 years to those people who are living with life-limiting or life-threatening conditions, and years to life to the family members who might follow on from them. So the argument is that we're about offering somebody the best possible afternoon that they can possibly have if they're experiencing a distressing symptom. What treatment, what other therapies, what services can be put in place if, let's say, Sam were experiencing distressing pain to remove as much of the distress associated with that particular symptom. So Sam can go out into the garden and enjoy what I'm looking out my window here is a glorious, beautiful spring day. And that's so important because that afternoon can't be revisited. So it is about adding life to that individual. And I'm much more interested in the living bit rather than a kind of societal preconception of what palliative care bit, which is all about dying.
Yeah, unfortunately, I think because of the association, lots of people don't access the incredible support and options that there are because they they associate it with the very end. And that's part of the reason that we're here is to, like really demystify that. And actually, in terms of getting that support, and Sam, how you've described that support, like regarding pain, but then Jonathan, what you were saying about some of the psychosocial kind of the things that just make life easier. How
Represents a
do we get
sort of
that word out?
It kind of represents the Swiss Army knife in terms of the clinicians who are brilliant with therapies and pharmacology and drugs. Nurses bring something incredibly important to the table as well. Beyond that, there'll be folk working in palliative care who have expertise in dietetics or in physiotherapy or occupational therapy or psychology, or for some individuals who require it, liaison psychiatry to manage some of the very distressing mental health related problems that might be associated with some individuals. And depending on the problem, different blades are brought out to manage the most important thing or the biggest concern for that person in that moment. In relation to studies that have focused on value added from palliative care to individuals who are living with life-limiting conditions was a study that took place at Massachusetts General Hospital a number of years ago, where one group of patients was randomly allocated to receiving best or usual care. These were patients with or individuals living with small cell lung cancer, and another group were randomly allocated to continue to receive that treatment, but then got this additional layer of care referred to as palliative care. Now, these individuals had discussions about their situations so they could understand what was going on. They had very frank and honest discussions about what they wanted, what their preferences were, what their values were, and very importantly, what they didn't want to continue. So the group who received palliative care had much better symptom control. Their symptoms were being much better managed. They had much better psychological support. They were more often than not likely to be cared for at home and to die at home. Their quality of life was improved. And the kicker is that they lived 25% longer than the individuals who received best or usual care.
Wow. I mean, that's a
It is an important
significant,
statistic in
yeah.
terms of they're making decisions about not necessarily wanting aggressive third or fourth line chemotherapy, which was associated with, I mean, Sam, I'm putting this over to you. This is a path that you have been down in terms of all the distressing symptoms that may be associated with treatment. And it's life sapping in terms of the labour associated with going down that particular path. And it was almost Zen like. There was a renewed energy once all the distress was removed from some of the very aggressive treatment to continue to live, to continue to be with people who those individuals loved, to continue to be sitting alongside a cat or a dog, to get into the garden, to recalibrate, to do the things that brought value to those individuals' lives.
I feel like palliative care, it needs a marketing.
So it's fair not to prolong life, although we obviously want to bring value. And if it so happens people do live longer and
Yeah.
enjoy those days to better effect, but very importantly, I think I'm very mindful to say that it's neither there to shorten life.
Sam, what do you wish that you had known before you received palliative care?
I don't know. I don't know what I wish I'd known. I can certainly, though, I mean, one thing that I did want to kind of bring in is that I kind of wanted to like let people know who might be facing this or might be kind of looking down, thinking this is something that may happen. Or when you finally then go in for that dreaded meeting, that meeting where they say that there's not much more that they can do. I mean, I can liken it very much to when I had my first diagnosis, where I kind of described that as sheer, unadulterated terror that you feel. And it's exactly the same when you sit down and you have that meeting with the doctor who says, well, certainly in my case, they said there's one more line of treatment, but it's not one that's going to be curative. It's just going to kick the can along the road. And when I had that meeting, obviously that's then suddenly transitioned me from hoping that I was going to get back to and continue to live some kind of life alongside my cancer to realizing that I'm not going to continue living. And I think the one thing that I like to obviously share with people is that terror wears off. It does. You can only maintain it for so long. Like that terror will go. And after a day or maybe two, you keep waking up in the morning and you keep going. And it's exactly the same as when you had your first diagnosis, when you had that initial scare. But when they say there's no more treatment, it does once again wear off. And you just keep going, you keep waking up in the morning. I do remember having a second meeting then when I didn't tolerate this last line of treatment. So obviously then I had the meeting about transitioning onto palliative care. Now obviously a lot of the kind of scare of that had been taken away by that first meeting, which had kind of set me up for this already. But I do distinctly remember being there with just an absolutely fantastic doctor and the CNS, so it's clinical nurse specialist, who had been there from the beginning with me, she had been in the very first clinic that I had with a consultant. She was there making sure that I was still doing all right. I think the doctor that I spoke to there really kind of changed my perspective.
Can I unpack, Sam, what sort of discussions you were having with that doctor and how this individual changed your perspective?
So it was very much, I think the main thing is that we probably don't have a very good idea of what dying looks like. And the way that she said in most cases it's quite a peaceful experience at home. Like no one it's really rare that we see or experience anyone dying, I think, in the modern world, at least in this part of the world. And I guess we're lucky in a case that is the truth, but it also means we probably don't have a very good idea of what dying actually looks like. And she kind of said that it's you will just get more sleepy with good palliative care. You're just going to get more sleepy, and eventually, hopefully, in a peaceful scenario at home with good care, you will just fall asleep, and that will be it. And that kind of relaxed me a lot. Like you kind of think of dying as being some terrible thing. And the other thing she said is you don't remember coming into this world, and you won't remember leaving it either. That's another thing that kind of brought me a bit of peace, and made me kind of embrace my future. Rather than just be completely terrified by it.
What does a typical day at the hospice look like, Sam, from your experience?
So, I mean, for me at the moment, I kind of I get up in the morning. I've got a lovely little deck out the front with a pond with lots of fishes in. So that they've allowed me. So certainly here they've been incredibly facilitating to let me kind of make my room as such while I'm here as I want it. So they've allowed me to bring in my coffee machine. So I sit here and I make myself a coffee and I get a big bowl of Rice Krispies and have coffee and Rice Krispies. When it's sunny, I might do that out on the deck, which is quite nice. Then I've been working on some programming projects. So I kind of generally sit and work on some of those, or I play some computer games. I mean, recently also I've been absolutely slammed by the number of people that want to come visit me. So that has been
Tell me how
absolutely...
that works in terms of the ability to entertain friends and guests and family.
Well, they're allowed any time of the day or night if they want to. They don't have any restrictions. Most of the time, obviously, they're not coming in the middle of the night, but they come round most of the time during the day, and we have a little chat. We can have a little walk around the grounds. We've done a couple of like movie nights as well, where we can all sit around here. I've got a TV in my room, and we all go and watch watch a movie together or something like that, which has been very nice. Another fantastic addition has been they've got here something they call the man shed, and it's essentially a workshop out in the grounds. So me and my dad have always had a relationship where we can be quite awkward speaking to each other at times, and obviously love each other to pieces. But it's allowed us to go out to this workshop and like work on a project together. So we're building a little kind of Robin box at the moment, and I think both of us really enjoyed that, and it's allowed us to really connect and spend some really good quality time together. At this time, and
And
all
I
of
think
that has
the
been
special
innate.
moments, precious moments that your dad will reflect on after this,
Yeah,
which
yeah,
can't be captured in and have no price in terms of the value that they bring people, you and him.
yeah, yeah. So all of that has been enabled by my stay here, and actually a lot of the stuff has been suggested by the medical staff. Certainly, the consultant here was adamant that I check out the man shed, and obviously she was dead on correct, because we had a fantastic time out there.
Oh, it sounds so nourishing on so many different levels, and a lot of space to make it your own.
Or let's just put that
Yes.
word there,
Mm,
normal,
Yeah.
as opposed to separate, distinct. I
Yeah.
think there is a concerted effort to normalize our attitudes around death and dying. And Sam, you picked up on the reality that many of us may not ever have witnessed a death of a loved one or a close friend. These were things which were far more common several generations ago and have been removed from common parlance. Of course, it would be great to bring it back into the round so people are less apprehensive and see death as part of the normal life course.
And Jonathan, have you in your work noticed that there are differences when people are in their 20s, 30s, and 40s? So I'm thinking sometimes when people are later in life, they've maybe already seen their parents go, for example, but people like Sam in their 20s, it might be the very first time that, these words, let alone these experiences being had. So, if he was much older, he might have seen his parents in a hospice, for example. Do you think that people in their 20s, 30s, and 40s have different needs and different ways to navigate this?
You're asking me how a watch works here, and
Okay.
it's complex.
Yeah.
Because every individual brings something different to the table in terms of how they make sense of the world, how they make sense of the inexplicable. But I think whenever we teach this to medical students, I'm always mindful to get them to think of other losses that they may have experienced in their lives, which had significance to them in terms of moving home, a loss of a relationship, the divorce of parents. We experience multiple losses in our life. Now, of course, the loss of a loved one or a close friend is incredibly profound. But it's what those other losses also represent is something that we often don't necessarily acknowledge and see as being relevant to us. But changing that narrative around death and dying and potentially including it into the national curriculum, where we become attuned to the reality that death has 100% prevalence. We will all die, is an important aspect of the life course that we do need to understand and to become more familiar with. So stories like Sam are merely stories, as opposed to things which we would rather not discuss.
Yeah, and that, that's really why we're here doing this podcast, is that these things aren't talked about. Actually, some of the descriptions that you've given about that terror not persisting, and images of movie nights, and Jonathan, you coming in and saying about that actually this normalizing, and perhaps, someone, if they're finding themselves in this position, it's about finding their normal in that situation. Like, what are the things for them? What is the version of the man wood shop
Can happiness
for them?
flourish? And if it is in
Yeah.
the man shed, move that person and anyone who is important to them to that location. And if happiness can flourish by the seashore, knock down buildings so that person can get to that place. It's about enabling those moments to exist rather than finding barriers.
And so thinking about this, and perhaps thinking about what you would want, is that a useful thing for someone who might be anticipating end of treatment options?
And thinking of things which, Sam, you may be more familiar with in terms of advanced care planning and advanced decisions to refuse treatment, I would argue that most people, irrespective of their state of health or their age, should think about moments of uncertainty in terms of what would they want and what would they not want to happen to them. Writing things down, sharing them with people who matter to them, so those sorts of decisions can be acted upon. But also to bear in mind that people are fickle and change their minds in relation to so many things. For example, being cared for and potentially dying at home, but also realizing that one should have the ability to change one's mind based on situation and circumstances about what they would then want instead. So having frank and open discussions with folk who will be walking alongside us during critical moments in our lives is so important.
Yeah, it really is. And, if someone's having maybe a tricky time having those conversations, actually talking to other people in a similar position, sometimes sharing information about how to bring up this subject, maybe attending something at a hospice in advance. I know lots of people have lots of different ideas. And at Shine, this is why we do the meetups. This is why we have these conversations going, so that they are kind of incorporated. Sam, have you had some of your Shine friends come see you, or is that planned?
I actually have. I've had a bunch of them came over, and we had a lovely little time here, watching the naming the fishes, and kind of chilling out and chatting to each other. So it's fantastic. And unfortunately, I've been pretty fickle when it comes to organising my life, and I need to try and sort out another one. But they continue to pester me to try and make sure that we get another date in, because it was really a fantastic experience and it was really lovely to see them. So I'm hopeful I can sort my life out and actually make sure that we get another date booked in, because I'm looking forward to it already.
Oh, brilliant. That is so lovely to hear, Sam. Jonathan, is there anything else that you would like to add, if someone's listening to this, that you think would be really useful to know about palliative care, about hospice, whatever stage someone is at?
Again, that's a really important question, Tatum, in relation to, I think the absence of knowledge creates uncertainty, which creates fear and apprehension and anxiety. But there are folk out there who possess highly attuned skills, and I'm talking of folk working in palliative care, again, whether it's in a hospital setting or in primary care or in hospice, who are trained and work together and communicate seamlessly with one another about particular people and the families who surround them, in order, once again, as I said to you before, in terms of adding value and life to those individuals at whatever stage of illness they might be, in order to make those moments matter. And also to be aware that there are some incredible resources for people to read and to view online in relation to what palliative care is. I'm thinking of the resources from Marie Curie or Hospice UK. Many hospices will provide some very useful information which is written in ways which is accessible and not scary.
Can either give you that knowledge in person, finding those resources online, and like Sam's friends, they all came and visited you, and you came and shared with all of us. We're in the process of sharing that knowledge right now. Thank you so much, Sam.
Thank you, Sam.
Jonathan.
It's been a great gift to be with you this afternoon.
Yeah, thank you very much.
Thank you. And thank you to all of you listening. If you want to find out more about what Shine does, come find us at shinecancersupport.org. There are meetups like we've been talking about. We have a program specifically for people with incurable cancer where all kinds of things can be discussed and normalized, and we also have a laugh. Sam's been along to that as well. Thank you to Radio Facilities for sponsoring our podcast. Until next time.
Not your grandma's cancer show.
Bye-bye.